Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Let's move on to typhlitis, typhlitis. This is neutropenic colitis, and look for a history of HIV or chemotherapy where you end up with necrotizing colitis, classically involving the cecum and terminal ileum. This tends to have more thickening and inflammation than you would expect with a C. difficile infection, and again, the key on a multiple choice exam is to look for that HIV or aplastic anemia or some sort of leukemia, lymphoma causing neutropenia. Castlemans disease causes giant benign lymph node hyperplasia. This may be related to interleukin-6 overproduction. Commonly, you see this in individuals under 30 years of age. In terms of mediastinal nodal involvement, this is most common in the anterior mediastinum. The lymph nodes may be calcified, and you rarely will see these enlarged lymph nodes in the abdomen, so expect to see this on the chest. Again, remember, this is a benign condition, and you may need excision of the lymph nodes to confirm Castleman's disease is the etiology for the massive lymphadenopathy. Let's move on to lymphangiomyomatosis, or LAM. This has an association with tuberous sclerosis, most commonly affects women of childbearing age, and has a clinical history of recurrent pneumothorax that you may see on a multiple choice exam question stem. A few things to remember in terms of imaging are that you will see multiple thin-walled cysts throughout the lungs, usually uniformly scattered throughout both lungs. You have an association with chylothorax, which is a chylous pleural effusion, recurrent pneumothorax, and you look for those thin-walled cysts that vary in size, surrounded by normal lung parenchyma. If they show you an abdominal CT or the top of the kidneys on a chest CT, look for the renal angiomyolipomas. And remember the association with tuberous sclerosis, although this can also be sporadic. Rosadorfmann disease is something I've seen several times in real life. It is a sinus histiocytosis with massive lymphadenopathy. This is an idiopathic proliferative disease, and most patients will present with painless cervical lymphadenopathy with fever, malaise, weight loss, and night sweats. There are a lot of ways that this can show up in terms of imaging on an examination. The scenario where I've seen this the most is when I'm reading FDG PET scans, and you see these masses that do show increased uptake that frequently end up going to biopsy and or surgical excision to confirm the diagnosis that this is Rosadorfmann disease. Although rare, you can also have renal involvement, and in some cases this will show a subcapsular hypodense infiltration that is said to be a characteristic appearance of this disease. You can go ahead and look up images of this online to see what this looks like. And let's close this out for now with Airway Chester disease, ERDHEIM, Chester, CHESTER. This is also a histiocytic process that is associated with bone pain, neurological symptoms, and the word lipogranulomatosis is something you could remember with this. In terms of imaging manifestations, look on bone images to see bilateral metaphyseal and diaphyseal sclerosis. Look for cystic disease in the lung, possible interstitial edema and pleural effusions, and look for cortical thickening in the long bones that spare the axial skeleton. In addition, you can see retroorbital deposition with retroorbital tissue, and you can see cholesterol in the eyelids and cholesterol emboli. This has something called the hairy kidney sign, which is perirenal soft tissue infiltration. And you can go ahead and look this up because it is an Aunt Minnie for this disease. and it basically looks like soft tissue around the kidney that to me looks similar to the appearance of a pericardial effusion where you have fluid around the heart. It's just in this case you have this well-defined soft tissue around the kidney that has perirenal infiltration. And lastly, let's talk about Langerhans cell histiocytosis. This is also a complicated disease that we could spend an entire episode on, but to hit some of the highlights, this is most common in kids with peak incidence of 1 to 3 years of age. There are many different forms of this disease, and the way this can manifest is so broad I can't cover it quickly here. It is worth spending some time to read about this, and you will probably see questions on this, most likely in pediatrics. If it is disseminated throughout the body, a term for that is Lederer CV disease, maybe. I may have said that incorrectly. Letterer-siwe, that's the disseminated version, Lederer CV. Then you have Hans-Schüller-Christian disease, which some people say is Langerhans cell histiocytosis in a solitary organ, but some a solitary organ or else potentially in the bone and the spleen. And finally, eosinophilic granuloma, which some people say is a solitary lesion, which will most typically be a bone lesion. There's no real Ant-Mini for this on imaging that I'm aware of, and a key is to remember that you have this system where it really depends whether this is involving only one organ, multiple organs, or diffuse in terms of your survival, with eosinophilic granuloma being associated with the highest likelihood of survival. And that, again, is the Langerhans cell histiocytosis process in only a single organ, which most commonly would be a single bone lesion. I will be putting up some summaries on my website, theradiologyreview.com, to go over a lot of these. It's worth your time to go through these, as painful as it is. These are often the types of questions that will set you apart from other test takers in terms of the board identifying you as someone who has a deeper knowledge of many of these topics. And I would expect multiple questions on these on the examination because they do encompass many organ systems. Thank you for listening. Please share this with a friend who may benefit from this. Remember, we're all in this together, and my hope is to simply provide some content that will help put some of these more difficult topics into perspective to help you study more efficiently. If there's any questions that you have or any topics that you would like me to discuss, feel free to reach me at theradiologyreview@gmail.com. I wish you all the best with your board study, especially in light of the ABR core examination being delayed at this time in 2020 when I'm recording this episode. And know that there are many who are here to cheer you on as you prepare for this big step in your career. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.